Thank you so much, and welcome to the imaging session. I would like to invite our first speaker, Dilraj, to talk about retinal diagnostic and Alzheimer's disease.
Thank you so much, and thank you for the opportunity to share some of our work today. These are my financial disclosures. So why should we, as ophthalmologists and retina specialists, care about Alzheimer's disease? As our population ages, the prevalence of Alzheimer's is expected to increase from 6 million now to 14 million by 2060. Alzheimer's has a very long, nearly 20-year continuum where patients are asymptomatic. And this gives us the opportunity to identify the disease at asymptomatic stages for either earlier clinical trial intervention, as we are seeing new drugs being approved by the FDA, albeit with modest effect, or potentially risk factor modification, which has been shown to be effective to at least slow down disease in about 40% of cases. Also, when we look at people, they would like to know that they are at risk for Alzheimer's disease relatively earlier in the disease process. So how does the retina play into this? The National Institute of Aging and the Alzheimer's Association have a gold standard ATN biomarker criteria for diagnosis of Alzheimer's disease, with amyloid and tau pathology typically detected using CSF assays or PET scans. But these accumulate in the retina as well and can be detected. Neuronal injury has been typically shown using MRIs, PET scans, or again CSF analysis, but we all know that retinal findings mirror the cerebrum and we can pick up changes there. And finally, there's a large unmet need for a low-cost, efficient, and non-invasive screening tool. So what type of retinal imaging can be used for this? We have conventional retinal imaging that we're all familiar with the OCT angiography, fundus photography, and then there's more proprietary retinal imaging using at autofluorescence for certain fluorophore uptakes, as well as hyperspectral imaging. So we're familiar with OCT angiography. We can measure vessel length, vessel densities in the macula, as well as in the peripapillary area. But it's important to recognize that what we are measuring needs to be repeatable because the magnitude of change in these patients is very small. What kind of changes do we see? It's across a spectrum. Here, for example, there's a control at the bottom and there's a patient with Alzheimer's disease at the top. And you can see that there's a progressive decline in their retinal microvasculature, as well as their ganglion cell thickness, the retinal thickness, and nerve fiber layer thickness. But it's important to recognize that before we develop any kind of algorithms or nomograms for this, we have to be able to screen for image quality. And it's important to create efficient pathways where we can only identify good quality images. In collaboration with folks at the University of Edinburgh, we've looked at color photographs as well as autofluorescence imaging and looked at vessel patterns extending all the way from the posterior pole to the periphery, and looked at changes in patients with Alzheimer's disease, as well as using novel techniques like applying masks using alpha shapes. What about patients who don't have a diagnosis of Alzheimer's disease yet, but have mild cognitive impairment? They have retinal changes too, and this follows a spectrum as well, with patients who have memory loss or amnesia associated with mild cognitive impairment showing more severe changes than those who are non-amnestic. What about patients who carry the ApoE4 allele and are at a genetic risk for Alzheimer's but are yet asymptomatic? There are subtle changes that can be detected in these patients as well. And our idea is to follow these patients over time to see if changes detect earlier in the retina in these patients as opposed to normals. We know that there are different nomograms for males and females using conventional retinal imaging, but these differences may be different in patients once they develop Alzheimer's disease, again suggesting that we need to recognize these gender differences in neurodegeneration. We also need to account for normal aging as we follow these patients over time, because ultimately the goal is to be able to measure changes in the retina as we assess the efficacy of intervention. What about the choroid? That's another opportunity for us to assess vascularity and structure, and we have collaborated with folks at Singapore to look at metrics and help to identify differences, again, across the whole spectrum of neurodegeneration. There's also data to suggest that as you lose microvasculature and as you lose tissue in the retina, there is ventricular expansion that can be detected on volumetric MRIs. And finally, all this data can then be input into machine learning algorithms where we can take image data, quantitative data, demographic data, and develop models. So for example, in the image on the left, this is an 85-year-old patient, and the model strongly predicts that the subject carried a diagnosis of symptomatic Alzheimer's. And you can see marked differences in the ganglion cell layer, the retinal nerve fiber layer, the OCT angiography as compared to the 72-year-old control on the right, which the model strongly predicted was a control. Such models can also be developed earlier in the disease process, where patients have mild cognitive impairment but not yet diagnosed with Alzheimer's. So what about proprietary imaging? Neurovision has received a 510K clearance from the FDA for a scanning laser ophthalmoscope that is looking at blue light to excite curcumin emission after it is ingested orally, and is able to detect perivascular amyloid for both risk assessment as well as prediction of cerebral amyloid as a screen prior to PET or CSF analysis. Hyperspectral imaging can be used where different frames are obtained by scanning the source wavelengths to generate a data cube, which can then be looked to identify spectral signatures for phosphorylated tau and amyloid beta. There are several companies looking at this, including two that have received breakthrough device designation by the FDA, Optina as well as Redispec. They're looking at a small field of view, combining this with a traditional fundus camera, but this is also very exciting. And then finally, we have blood-based biomarkers, including recently phosphorylated tau 217, which is very promising and has also received breakthrough status by the FDA and is currently under review for approval. So where are we in 2024? Can we reproducibly detect changes early in the continuum using retinal imaging? The answer is yes. Can this be done using conventional retinal imaging? The answer is yes. Are these changes specific to Alzheimer's disease? No, not yet. All the work that has been done on retinal imaging typically excludes conditions that could affect the retina, including ocular conditions as well as systemic conditions. So the future lies in clinical care pathways that converge imaging and blood-based biomarkers as a risk stratification tool. And with that, I would like to thank you for your attention and thank our entire team.
Thank you, Dilraj. And I'd like to now invite Kyoko Ohno-Matsui to talk about polarized-sensitive OCT to visualize the course of posterior scleral fibers in various pathologies.
Thank you, Nadia, and thank you very much for this opportunity to speak today. This is my financial disclosures. Sclera is the outermost coat of the eye, and it consists mainly of collagen fibers. With OCT, various pathologies of the sclera have been found, such as dome-shaped macular posterior staphyloma and possibly pachychoroid spectrum diseases. However, conventional OCT could mainly tell whether the sclera was thick or thin. Polarization-sensitive OCT, or PSOCT, can analyze stitch properties based on how they change the polarization of light. It has the capability to visualize the orientation of preferentially aligned collagen fibers by measuring the net birefringence. So the purpose was to reveal the detailed collagen fiber organization in various scleral pathologies with PSOCT. First, I'll show you a relatively normal pattern of scleral fiber arrangement. We chose highly myopic eyes because the sclera is visible in its entire thickness. The optic axis image with PSOCT shows the orientation of collagen fibers. Orientation is color-coded, blue for horizontal, yellow for vertical, and pink-green for oblique. A horizontal scan shows horizontal blue fibers from the optic disc toward the periphery in the inner sclera. In contrast, the orientation of outer scleral fibers is vertical. A vertical scan shows horizontal fibers in the macula alongside oblique fibers upper and lower to the macula in the inner sclera. For intuitive axis visualization, streamline volume rendering is conducted using a software, ParaView. The left is an image viewed from inside the eye, which shows that fibers of the inner sclera extend radially from the optic nerve toward the periphery. The right is a view from outside the eye. Outer scleral fibers show vertical and oblique orientation. Then scleral pathology. Dome-shaped macula was presented last year, but as a reference, I will briefly show this. In the vertical scan of optic axis image, the dome shows the aggregation of inner scleral horizontal fibers, while other regions mainly consist of vertical fibers. In the dome area, yellow fibers of the outer sclera are not thickened and rather compressed. Streamline image from inside the eye shows the intense aggregation of horizontal fibers across the macula. Next, we examined posterior staphylomas, especially their edges. This patient has inferior staphyloma. In the fundus image, as well as a vertical scan or wide field OCT, the upper edge of the inferior staphyloma is seen. Optic axis image shows that horizontal blue fibers are aggregated at the staphyloma edge, just like dome-shaped macula. This case has wide macular staphyloma. The upper edge exists far upper to the macula. In the optic axis image, horizontally running blue fibers are aggregated, like the previous case. In the streamline image, the aggregation of horizontal blue fibers, which are normally seen across the macula, are displaced and are seen along the upper edge. And upper and lower to this edge, opposite directions of oblique fibers are seen, like they are dragged toward the edge. This may suggest that both dome-shaped macula and staphyloma edge are not simple thickening of the local sclera. These pathologies may be a consequence of uneven distribution and dislocation of inner scleral fibers. Finally, I'd like to show a novel finding identified with PSOCT. While examining streamline images, we observed unique fiber arrangements resembling spirals. We hypothesized that these spirals develop around the intrascleral vessels. To reveal this, we used the ANFAS detection of intrascleral vessels first. Left image shows the real-time depth of the scans, and right image shows ANFAS scans at the corresponding depths. You can see many intrascleral vessels. And left image is the same real-time ANFAS image. Right panel shows the streamlined images of the scleral fibers at the corresponding depths. You can see many spirals at different depths. And this is a magnified image. You can clearly see many spirals. This is an overlay of the ANFAS image and the streamlined image. You can see that these spirals correspond to the course of intrascleral vessels. ICG angiography showed that most of them were short posterior ciliary arteries. And such spirals are also seen at the exit of posterior vortex veins. Arrow shows the exit of this vortex vein. In ANFAS intensity image on the left, the exit is seen here, and in the streamlined image, the spiral is seen around the exit. And this spiral structure is maintained even in extreme conditions. In eyes with pathologic myopia, we sometimes see scleral pits within the atrophy. OCT shows full thickness defects at the pit. And in the streamlined image on the right, you can see spiral around the pit. In pathologic myopia, thin sclera and enlarged emissaries are structurally vulnerable. Spirals, or more accurately, coils, may prevent the enlargement of scleral defects and eventual rupture of the eye. These spirals likely exist around the peripheral vortex veins and may influence its blood flow through the sclera. In summary, PSOCT shows clear distinctions between the inner and outer sclera, suggesting they have different roles. Staphyloma edges and dome-shaped macula may be a consequence of uneven distribution and dislocation of inner scleral fibers. PSOCT reveals a previously unreported spiral arrangement around emissaries. It allows us to visualize qualitative aspects of the sclera, offering new insights into scleral pathologies. Thank you very much for your attention.
Thank you, Kyoko.
To have Bailey now, and then Rick. So Bailey, Rick, David.
Perfect. Thank you. So I'm going to invite Bailey Freund to talk about insights into disease mechanisms revealed with high-resolution OCT.
Thank you, Nadia, and I want to thank the program organizers for inviting me to present at this meeting. This slide has my disclosures. I'd also like to acknowledge my research collaborators on this paper. So the purpose of this talk is to demonstrate how observations from clinical pathologic correlations in AMD can inform our interpretation of enhanced imaging capabilities and help us better understand disease mechanisms. This has been the goal of a collaboration I've had with Christine Curcio for over a decade, and we've looked at things like type 3 macular neovascularization, shown at the bottom of this slide, which has been presented previously at this meeting. High-resolution OCT, or high-res OCT, is a modified spectralis device with increased axial resolution of 3 microns. This is an example of high-res OCT in an eye with AMD and geographic atrophy corresponding to C-RORA. We can see details of the retinal anatomy that approach histologic levels, and the CAM group has used these findings to develop new nomenclature, such as C-RORA, and also to define clinical trial endpoints. Here I'm showing collapse of a drusenoid PED in an eye with AMD. The drusenoid PED contains a calcified drus. And when the drusenoid PEDs collapse, what happens is we get what we refer to as a sealed RPE defect, as Mueller glia become activated and infiltrate into underlying basal laminar deposit and Brooks membrane, sort of creating a seal and recapitulating an external limiting membrane. That was shown by that work by Molly Edwards and co-workers in Jerry Luddy's lab at Johns Hopkins. Christine Curcio and I have shown similar findings here in an eye with C-RORA. You can see the Mueller processes infiltrating into basal laminar deposit, which drapes 2 calcified drusen. And you could imagine how difficult it would be able to separate the retina from that underlying tissue. Here's another eye showing a similar thing. You can see that there's artifactual detachment, and because of the infiltration of the glial processes into the underlying tissue, it really creates this seal. And this is sort of past the point where you could do RP transplantation or likely put in photoreceptors. Here's the high magnification of this sealed RPE defect. Sealed RP defects are probably most common when we see flat RPE in AMD or other diseases, but occasionally they can occur over RPE detachments where that structure remains elevated. Rick Spaide recently published a case like this, but similar process. You lose photoreceptors, RPE, and then you sort of have this seal that is somewhat a barrier to fluid getting into the overlying retina. Here's another example in a patient with central serous where we see the formation of a sealed RPE defect where there's complete loss of the RPE and photoreceptors over that persistence of that dome structure representing the prior serous PED. What I want to show now is what would the OCT look like if we developed an RPE defect prior to there being irreversible loss of the overlying photoreceptors so that the ELM remained intact. So here's a drusenoid PED going through the same process of collapse. But notice that once the drusenoid material, the basal linear deposit beneath the prior RPE goes away, interestingly, we start to see reconstitution of both inner and outer segments, and the ELM has remained intact. So here's high-resolution OCT showing that. It's not a perfectly healthy photoreceptor layer, but we can see that there were previously no inner and outer segments. Now there's some reconstitution, despite the fact that there's persistent fluid and the complete absence of RPE in that area. This is the same eye showing that there is one area where there is a sealed RPE defect, where there is loss of RPE and photoreceptors at one edge, but for the most part, this is an unsealed defect. We can think of unsealed being most common in central serous, like a CSC leak, but occasionally, as I showed before, in this case, we can get these unsealed defects in AMD, which might represent an opportunity for intervention. So here we can see resolution of the basal linear deposit beneath the RPE, and once that material goes away, we actually see production of inner and outer segments, and actually now we form this vitelliform lesion, and you can see the ELM and the ellipsoid zone is still present overlying that unsealed defect. These lesions that we're calling unsealed RP defects have been called other things in the literature, including apertures, SMARPE, microrips, atypical RPE defects of the, with retained photoreceptor layer. So basically, we're describing the same thing. The formation of unsealed RPE defects is not just in AMD or CSC, but you can see it in other diseases, such as this patient that has a pathogenic mutation in PRPH2 and a pattern dystrophy, and you can see some retention of the photoreceptors and the ELM over that area. So the take-home message here is that we define two types of RPE defects, sealed and unsealed, which can be seen in a variety of different diseases. RPE defects that are beneath a disrupted photoreceptor layer often become sealed as activated Mueller glia infiltrate underlying and surrounding tissue, but RPE defects that occur prior to the complete loss of the photoreceptors can remain unsealed, and there I think there is a potential possibly to recover vision in those situations. So I'd like to acknowledge my coworkers and colleagues. Many of these were prior fellows on this project, and once again thank the program committee for inviting me to present this work. Thank you.
Thank you, Bailey. And we have a small switch in the program. We're swapping the next two talks. So next I'm going to invite Rick Spaide to present on a new method for measuring blood flow from OCT imaging.
Thank you for allowing me to speak. So these are my co-authors, and these are my disclosures. So abnormalities of blood flow are really at the heart of a lot of blinding diseases inside the eye, including vascular occlusions, diabetic retinopathy, age-related macular degeneration, even glaucoma. We have ways to measure blood flow now. One of the most common ways that we do it in the clinic is fluorescein angiography. Now we have these kind of crude measures like AV time or arm to eye time and the like. But even from these crude measures, we know that, say, if you had a carotid artery stenosis on one side, that the flow would be slower on that side and the arm to eye time would be slower. There's instruments that can measure blood flow inside your eye. Laser flowgraphy is not depth resolved, neither is laser Doppler. Doppler OCT is depth resolved, but it requires a complicated instrument that's expensive, hard to maintain. All of these things require separate instruments. Wouldn't it be great if we could just use a clinical OCT to measure blood velocity in whatever blood vessel you wanted to measure? Now we're going to do OCT anyway, so it's no big deal, and if we could use the instrument we already have in a clinic, it would be pretty inexpensive. So let's look at this movie, and here's areas of blood vessels inside the retina, and can you see where the blood flow is? It's kind of easy, right? We can see that there's areas where the speckles change pretty rapidly, but what about the speckle character? Well, that goes by too fast for us to see, but I'll show you single frames. So here's one frame, and then here's a few tenths of a second later. And maybe you don't see the difference, but here's the blood vessel, and I'll show that close up. And you can see on the left-hand side, there's these large blob kind of speckles. They're horizontally located or oriented. On the right side, just a few tenths of a second later, there's many more speckles. They're smaller, and they're vertically oriented. Now, I made a drawing of what speckles could look like, and just to show you how, using image processing, you can tell the difference in a pretty easy way. This is going to bring back post-traumatic stress disorder from people from calculus days, but you can take a horizontal derivative across this, and that shows us the vertical edges. And all we have to do is measure the grayscale value in each one of these things, and we can scale that up and show that as a movie, and it looks like that. Does that look kind of familiar? Well, we just made some kind of relative value scale and plotted that, and it looks like this. It looks like a waveform, right, from a pulse cycle. We then looked at Doppler OCT and validated that this actually matched Doppler OCT almost exactly, and found that those periods where there's small vertical speckles was when there's peak blood flow. So then we made a model eye and looked at blood flow in a model eye through capillary tubing as determined by a pump. And found this is the relative value scale that we just invented. This was like an arbitrary thing versus the actual flow for human blood. And we also did this with porcine blood as well. And you can see it could be fit with a power law curve, and that power law curve had an R squared of 0.983, which is pretty good. So if I tell you the relative value, I could tell you, if you tell me the relative value, I could tell you the actual blood flow quite accurately. Now there's a curious thing about blood vessels when you look inside the eye. And when you look at an averaged image, they have an hourglass shape. Do you know why they have that shape on the inside? As it turns out, when blood is flowing quickly in blood vessels, it has a very structured arrangement, and this exists in every one of us every second. When blood is flowing quickly, the red blood cells align themselves to the outer wall of the blood vessel, and all the blood cells on the inside of that align themselves correspondingly. So for a brief instant in time, all the blood in our blood vessels is very organized structurally. And I think the multiple scattering of this causes those fine speckles that we see. In slower blood flow, it starts to lose that organization. And even slower blood flow, you recall that red blood cells will start to align themselves in coin-like fashion, and we call that rouleau formation. So I think at these really low shear rates, these, by the way, are all physiologically relevant inside the eye. At the low shear rates, you get those big clumps of RBCs, the rouleau formation. At the high speed, you get that structured arrangement, and that causes those speckle kind of character that we see. So let's see this in practice. Here's just a fellow eye of a person who had a vein occlusion. So you can see the red ROI, the red circle, corresponds to an artery, and you can see the pulsatile nature of the artery. And the green one shows the corresponding vein. And you can see that the vein is bigger than the artery, as we kind of expect. Maybe the peak flow is less, but you can also see there's a phase delay between the peak of the artery to the vein. Here's the central retinal vein occlusion eye. And you can see that there's a kind of a bounding pulse in the artery. The venous one looks a little bit lower. And if we compare these things, you can see that the peak in the artery is higher, the trough is lower, and the vein flow is even lower. Now, this is something that seems kind of strange to us, but people have known this for decades by looking at ultrasound. Doppler ultrasound, say, of the kidney, if there's a vascular occlusion, shows this exact same pattern. We didn't know about it in the eye because we didn't have a way to measure it before. Let's look at a patient with polypoidal. Yes, this actually works in the choroid as well, so we can measure blood flow velocities and vessels in the choroid. Here's a vein next to that. There's one curious thing about the choroid is the choroidal veins have kind of a slow flow and they differ one from another. But we can also measure the blood flow inside the polyp, and you can see that it kind of matches that of a choroidal vein. So this could be a good way to, say, measure the response to treatment in polypoidal choroidal vasculopathy. So it's a pretty simple technique. You should be able to do it with almost any OCT instrument. I showed you exactly how it works, and I think it should have pretty big clinical applicability since we can look at both retinal and choroidal blood vessels and measure flow in those vessels. I think it has a huge potential for helping our understanding for ocular disease since we have no other alternate method in a clinic actually to measure blood velocity and correspondingly flow. And I think it's applicable to systemic disease as well. You recall back to the carotid artery stenosis. We look on fluorescein angiogram, what you would think that it would also cause a decreased flow velocity. Ever since the time of Helmholtz inventing the ophthalmoscopes, we learned in medical school that the eye was the only place that we could see blood vessels, and now it's actually a place that we can actually measure blood vessel or blood flow velocity. Thank you for your attention.
Great talk, Rick. And I am now going to invite David Sarraf to talk about advanced retinal imaging, when and why and which one.
All right. Thank you, Nadia, and the organizers. It's a real pleasure to be here. We've had two beautiful presentations, three actually, on specific imaging techniques. This will be more of an overview. And I'll try to, in this overview, go through a number of different more innovative modalities that you may be less familiar with and how we use these modalities to drive diagnosis in the clinic and increase our level of care. And this will start with a case presentation. This is an elderly patient, came in with vision loss in the right eye, with macular degeneration, but there was no heme on exam. And on OCT, we only saw SHREM, subretinal hyperreflective material, but all the B scans were dry. There was no evidence of subretinal or intraretinal fluid. The SHREM material lit up on the autofluorescence, and we thought, oh, maybe this is just vitelliform material. It just stained on the angiogram, and there was no evidence of neovascularization until we did OCT angiography. And OCT angiography showed flow, a type 1 neovascular membrane. We had our diagnosis. We arranged urgent anti-VEGF therapy, and sure enough, after the therapy, the vessels resolved, the SHREM resolved, and there was commensurate improvement in vision. And this is an example of how OCTA can be a very powerful tool in your clinic to help diagnosis.
We did actually a study looking at OCTA differentiation of all the different etiologies of SHREM, and there are many, including blood, exudation, vitelliform material, fibrosis, and neovascular membranes. And here you can see a patient with vitelliform material. There's no flow on the OCTA. In this patient, there's a fibrous scar, there's projection, and in this patient where you actually have a neovascular membrane, you can see true flow, and so OCTA can be a very powerful tool to differentiate SHREM. There are other conditions where you may only see SHREM without fluid, and that includes myopic neovascularization, and OCTA can be very powerful to detect neovascularization, active NV in the absence of fluid, and also in PIC, we can see SHREM in the absence of intraretinal and subretinal fluid, and so OCTA can be a very powerful tool. It's also a very useful tool to detect type 3 RAP lesions. You can see the flow descending from the deep plexus into the RPE and causing a large serous PED, and after anti-VEGF injection, you can see resolution of the flow on OCTA and resolution of the PED. We can also use it to detect the early onset of RAP lesions, which tends to develop after outer retinal atrophy, and you can see the flow in the bottom panel after this patient developed atrophy over this large drusenoid PED. OCTA is also a really good tool to detect non-exudative MNV, and it has really increased our sensitivity to detect this lesion, which would require more careful follow-up as these patients are at very high risk of exudation and associated with that neovascular lesion. Non-neovascular fluid is also a very important clinical context that you should be familiar with. There should not be a knee-jerk approach to treating fluid. Patients with large drusen can develop non-neovascular fluid, and OCTA is a very important tool to rule out that neovascularization. And instead of a treat and extend approach, you should have an observe and extend approach in these patients with non-neovascular fluid over a large drusen. Inflammatory diseases as well, OCTA can be a very powerful tool. In placoid diseases like AMPI, we showed that OCTA can detect interchoroidal ischemia, and this is really the sine qua non feature of placoid diseases like AMPI and persistent placoid chorioretinopathy. And the flow deficits you see on OCTA co-localize beautifully with those deficits on ICGA, as you can see on that panel. On-fast OCT is also a very innovative, powerful imaging technique, and we've used it to identify various vitreoretinal disorders, including epivascular glia that we could only see with scanning electron microscopy. In addition, we've used it to study ILM tears, and here you can see an ILM tear. There's the margin of the tear. There are the associated dimples, similar to the surgically induced dimples you see with ILM peel, and often associated with paravascular inner defects. We've also used on-fast OCT to characterize the trizonal distribution of drusen. Soft drusen tend to occur in the central circle where cones are most dense, whereas the dot drusen tend to aggregate in the inner and outer circle, the dot and ribbon SDD in the inner and outer circles. We also use on-fast OCT to characterize the progress and identify atrophy and specifically C-RORA and hypertransmission defects. And this is especially important now in the era of anti-complement therapy to track these areas of atrophy and actually measure them with great accuracy because we can identify the margins very precisely. And so on-fast OCT quantitation and characterization of atrophy and monitoring the progression of atrophy is a very powerful application of this tool. Fundus autofluorescence is also a very important tool in retinal toxicity. I use fundus autofluorescence in patients with plaquenil toxicity. Here you can see this very subtle area of hyperautofluorescence in the infratemporal area that co-localizes with this area of ellipsoid loss, in this case an Asian pattern that was more eccentric. And here you can use autofluorescence also to track the progression of plaquenil toxicity in the macula of both eyes. Autofluorescence also a very powerful tool for pentosan maculopathy. You heard a prior lecture about this. We've screened now prospectively, the only prospective study, over 150 patients. These were the 24 who were affected, and fundus autofluorescence shows a very signature speckled pattern, and you can see progression in many patients off medicine. Near-infrared reflectance can also detect the deposits very early in the disease, and here you can see a patient who had progression over 10 years of monitoring. We also use fundus autofluorescence in MUDES because the lesions you see on color fundus photography are not as well visualized as they are on fundus autofluorescence, and that can be a real excellent tool to see the spots of MUDES. And finally, ICGA is a very important technique as well. It's very important to identify the hyperpermeability in a CSR, and we also use it in patients with polypoidal to identify the branching vascular network and the aneurysms and polyps, which are not as well seen even with en face OCT. Thank you for your attention.
Thank you so much, David. And I would like to invite Amani Fawzi to lead the panel on OCT imaging. I was going to say my Sparta doppelganger, but
Thank you, Nadia, and I'd like to invite my panelists. So we have sort of an eminent group of who's who in retina. So I was inspired by my panelists to focus on AMD. And the trick here is I'm going to ask them to squeeze as much information out of the OCT as possible and try to get through as many cases as we can with AMD. So our panelists are, as you see here, Dr. Heier from the OCB and Dr. Deeba Husain, Dr. Peter Kaiser, Eleonora Ladd, and Daniel Ting, our AI expert. So we'll try to employ their skills to squeeze as much information out of this OCT. So Peter, you're sitting right here. So what does this OCT tell you? This is all AMD. There's no sort of diagnostic trick here.
So, if this is the first time I'm seeing a patient, there's a few things that I'm concerned about. First off, that very peaked PED, I'm thinking maybe this is a polypoidal type lesion. There's an RP rip temporally there where you can see there's a lot of hypertransmission. There's subretinal fluid. So the big question is if the patient has been treated before or not, and if they've not been treated before, the decision whether to treat is the one we'd have to discuss with the patient.
Awesome. Awesome. So as Peter said, this is a 2060 patients. They've got subretinal fluid. They've got a peak PED, that irregular pattern that Jimmy and Judy taught us about. Suggests maybe a polyp hiding in there. And you could see sort of, if you look in the choroid, there's an area where the choroid is dark, tells you that's where the RPE is rolled. And then next to it is an area where there's a lot of transmission where there's no RPE. And the question comes up now, the RPE is ripped already. Is this patient worth investing more injections, or should we just throw the towel here? So anyone need more imaging to diagnose AMD? So when you see a patient in your clinic and they've got the age group and the fluid, do you still get fluorescein angiography, Jeff?
Yeah, so I rarely get fluorescein angiography now. I usually get it in patients who don't respond to anti-VEGF therapy that I'm concerned about masquerade syndromes. And I wouldn't get it in this patient. I probably wouldn't get any additional imaging in this patient, and I would initiate anti-VEGF therapy in this patient if they hadn't already started it.
Awesome. And Deeba, would you think about OCT angiography or any other imaging modalities here?
At this stage, for diagnostic purposes, I don't think there's need to do any more imaging, but prognostically, I think to get an autofluorescence, it helps map the area of the rip to monitor it as time goes by.
Great. So we did have an autofluorescence, and I agree with you all. I rarely get a fluorescein. I think in AMD we sort of dropped the angiography out of the dye angiography out of our armamentarium almost all. And so here, what I'm seeing is sort of preservation of the RPE just under the fovea, and the rip, luckily for this patient, spared the fovea, so they're good candidates for continuing to treatment. And so we went ahead and continued treatment, and as you all sort of surmised, this can have a pretty amazing outcome. So this patient seems to have sort of reconstituted what seems to be RPE, maybe pseudo RPE, and their vision has continued to do great, and everything collapsed, and we've continued to inject them with very, very good outcome. So here's our next case. So Dan, you're up. So this is a 73-year-old, first presentation. She says her vision's been wavy for 2 to 3 months. This is now 2018. So what are your thoughts?
Well, it looks like, there's CNV below and above the RPE, so type 1 and 2 there, and there's subretinal fluid as well as the shroom. So yeah, I'll work on working diagnosis of it. Yeah.
Would you just start treatment, or would you want more imaging? Or?
Well, I would do FA and ICG. So I do. Yeah. So the previous case, the ICG is something that I would actually potentially add it. To the earlier case, and same as this case as well. Yeah.
So you would get an ICG on. Is that sort of your standard? You get ICG because
I think the Asian population, PCV is quite prevalent.
That's a great point.
But Dan, will it modify your treatment at all?
I think if you actually, I think the presence of polyps does actually play a big role in terms of managing the PCVs. It does. Yeah. So if I'll usually look at the polyps, the presence of polyps, and I'll repeat the ICG. In fact, 3 months later to look at the polyp closure. Yeah, that actually determines the long-term treatment, the management plan as well. Yeah.
Okay. Peter?
Yeah, the one thing we can't really tell, because the bottom part's a little off, is this looks almost like pachychoroidal neovascularization. So to me, I would want to get an OCTA first off. And the other interesting finding on the en face is you can see there's thinning of the retina inferiorly. So a fundus autofluorescence wouldn't be unreasonable, but that would be within the pachychoroidal spectrum.
Super. So we thought there was type 1 and type 2 CNV, and there was definitely SHRM. And when you see SHRM, Nora, does that make you think of something prognostically, diagnostically, therapeutically?
Certainly. So it does portend a higher risk for fibrosis, which is not a good outcome in my patients, even when they're adequately treated. But I agree with Daniel. I would get all the imaging as well to characterize this patient up front, because PCV is not common just in the Asian population. We see quite a few cases, and to Peter's point, we wanted to pick it up.
Yeah, as Judy told us earlier, 20% of Caucasians even have polypoidal, and we don't think about it in the U.S., and I think we miss a lot of it. And it sort of changes how you treat them and what you treat them, and whether you consider PDT. So it is a great idea. So we discussed all this finding. So, I'm sort of a minimalist, so we didn't get any more imaging, but we did get autofluorescence. And here, in addition to having the fluid and everything, the other eye sort of gives us some sort of inclination that this patient has reticular pseudodrusen. They probably have very higher propensity for atrophy. But we did go ahead and start treating, and we have the luxury of 7 years follow-up on this patient. And as you all sort of suggested, that SHRM was not a good sign to have at the onset. So despite our valiant efforts to treat this patient very aggressively, the combination of SHRM and her potential reticular pseudodrusen sort of increased her tendency to have both atrophy and fibrosis, which I think Voss coined the term atrosis. So it's really this new era where we're seeing the combination of atrophy and fibrosis in the same patient because of the pathology. So we'll start now with a new case, case 3. And again, 2 slices of the OCT in the same sort of eye. And Nora, maybe tell us what you see here.
I see some area of atrophy, which I pay attention to these days, and drusen, and no fluid in this particular patient.
Cool. So any more imaging you want, or?
I would obtain an autofluorescence. If it's initial visit, I do get an FA, but that's our typical protocol.
Right. There's no FA, but that's okay. But so I agree. And we saw this sort of thickening between the RPE and Brooks membrane, and it's got two intensities. There's a hyper-reflective area and a hypo-reflective area, so double layer sign, and it's sort of two intensities, so you worry about that area. And what would you do, Peter?
You know, I think this is a case that you'd want to get an OCTA. So that double layer sign, the worry, of course, is that's the non-exudative C and V, and that'll determine your follow-up versus this is just an intermediate AMD patients they'll see in 6 months. The other big important thing about this is, let's just say you're deciding to treat the atrophy, and this is a patient with a double layer sign. We first learned this in the Philly study that the patients who developed C and V from the complement inhibitors, many of them had double layer sign at baseline. So it's just a poor prognostic sign if you're going to treat a patient with a complement inhibitor that you want to really warn them that this may proceed to active exudative CMV.
So this is so critical. So then with this era where you have this combination, so sometimes the OCT can save you before you start offering, or if the patient's thinking about these drugs, you tell them they have this much higher risk, almost twice as high risk of progressing to neovascularization and bleeding. So you take a very stable sort of quiescent situation and turn it into a more eruptive. So this is double layer sign with geographic atrophy. So you think about these things when you're initiating treatment. So we got a fundus autofluorescence, and even though the vision was 20/20, we were sort of puzzled. This autofluorescence tells us the atrophy is going through the center. And so Jeff, does that make you question your OCT, or how do you deal with this?
Sometimes with fundus autofluorescence, it can be hard to see where the atrophy is, so you can do something like near infrared to help highlight that.
Awesome.
But the other thing is the double layer sign may be protective if you've got foveal sparing.
Super.
And so this is somebody that you would not want to initiate therapy on if there wasn't clear evidence of leakage.
So you read our paper, thank you. So with Hisashi Fukuyama from Hyogo University, we published a year or two ago about double layer sign and how that can be protective. And so you want to really watch them closely and to sort of give them a good prognostic sort of silver lining to their double layer sign. So here, as you can see with the near infrared, it outlined that subfoveal preserved RPE much better than the fundus autofluorescence because of the blue blockage from the pigment. So be aware of that. And we did get a OCT angiography, and it did show us that that double layer sign had a sort of a very nice layer of neovascularization in there, preserving the overlying RPE and hopefully protecting the vision. And so think about this, watch these patients carefully, and think a lot before you offer a complement in these eyes. And so I think, Deeba, you're on. So here's a 71-year-old. This patient I share with Dimitra across town. And so sometimes the difficult patients, we sort of send them back and forth to see what would you do. So here's a 71-year-old with subretinal fluid. And what would you do? Do you think this is for sure neovascularization?
So there's some shaggy appearance of the outer segments indicating chronic fluid. On the near infrared, there's this pigmentation pattern, again indicating kind of chronic fluid. I don't see any evidence of choroidal neovascularization here. The OCT showing that the choroid is thickened, so chronic central serous is what I would pachychoroid spectrum is what I would think about more than AMD in this case, based on this one OCT.
Absolutely. So this is really the elongated photoreceptors tell you this has been going on for a while, and they're able to survive in this fluid environment. So that kind of tips you to this pachychoroid and then the thick choroid underneath. And so here's the sort of the autofluorescence. And, you know, he's a male. Do you consider pentosan, polysulfate? Anyone? I mean, the pattern is very, very reminiscent. So what does this autofluorescence give you? Any more information you get out of this?
Just that the subretinal fluid is tracking down. There's evidence of a lot more fluid in the past.
Yeah.
So the
this
hyperautofluorescence inferiorly
Yeah.
and the tracking goes more in favor of pachychoroid.
So you can get a lot of information without the dye. So that's just, I'm just saying, you don't need the fluorescein to give you that information. So.
OCTA was very helpful in the prior case of the double layer sign.
All right, we can, but that's still no dye. Still no dye.
You know, these are common cases that are sent to us for second and third opinions, and it's tough. You get an OCTA, you see that there's no neovascular complex, and then the challenging thing is explaining to patients why they've had 2 years of therapy and no response.
It's true. That is true. And you know, it's sort of the fellow eye kind of gives you the same pattern, and there's fluid there, and it's hard to tell them not to do anything. So when I saw the patient, you know, I did what you all did. I did a OCT angiography, and I didn't find anything. And I told Dimitra, you know what, no one should leave our clinic without a trial of anti-VEGF. So I sent him back to Dimitra, and I said, let's just give it a try. Well, you know, no one should leave without anti-VEGF. And so even though we didn't think there was, so Dimitra did a valiant try of 2 or 3, and then it wasn't until she stopped injecting that he got better. So he got better 2 years after stopping the injection. So sometimes giving the injection sort of makes the patients feel better, makes us feel better that we tried at least. And if there's no leakage and there's nothing really dramatic to treat on PDT, you can monitor those patients, and they end up with pretty good outcomes.
But I think the key to that is trying it. You don't see a change, and so if you don't see any response, then you move to something else.
Absolutely.
But I would also think about doing an ICG in this patient and considering PDT before I would do anti-VEGF injections.
Absolutely. I think you're all absolutely right. I'm just saving the information from you.
Well, and also in the choroidal en face slab in OCTA, you see the choriocapillaris island. So there's a choroidal island, which really points mainly to central serous. So that really helps you with the diagnosis. So you knew anti-VEGF would have minimal to no effect.
Right. But I mean, I think it sort of makes the patients feel better. We tried something, and I think, there was hopefully, in the end, everything ended up good. Any other?
Yeah, well, if you actually got the information for ICG, you're straddling between like the CSR or like the PACI neovasculopathy, that kind of spectrum, and sometimes the half fluence PDT could be beneficial.
Right.
Yeah.
Absolutely. If you find something to treat, PDT can be magical. Yeah. You could just, if it's extrafoveal, as Sophie earlier said, if it's extrafoveal, you can do full fluence. If it's subfoveal, you maybe do a lower fluence, and that could sort of be a long-term prognostic and therapeutic outcome. So here we thought this was pachychoroid pigment epitheliopathy with no CNV. We did try anti-VEGF, and then the patient got better on their own. So this is our sort of extra credit case. This patient came in insisting that all her symptoms started a few weeks ago. She's having intense distortion, metamorphopsia, very unhappy. The referring doctor was expecting, we need an answer for this patient and what is going on. Nora, do you want to take this one?
This is fascinating to me because the first thing I see is choroidal hypertransmission. Makes me think of GA, but obviously there's no GA. You can see the RPE, but there's a PED that is lucent, almost looks like a serous PED, but this is not a regular serous PED because of the outline. The EZ is missing, so I'm not surprised that the patient's having this distortion. These are called ghost roos. They're fascinating creatures.
That's the Duke activity. So, I sat there and I looked at that OCT for a very long time, and I was puzzled. How could you have both serous PED and hypertransmission with an RPE? And so it is definitely a ghost ruse, and the clue here is this hypertransmission under the sort of translucent RPE. And so what's going to happen to this patient over time? We watch the fundus autofluorescence. Again, this fundus autofluorescence, because of the location, had this kind of normal hypoautofluorescence. But over time, what happened is the drusen collapsed, and we got a frank geographic atrophy in this area. Anything else you guys see on this OCT?
Well, I think it's just important to recognize this, right? This is a very strange-looking ghost druze. Usually they have some homogeneous debris within where the druze used to be, where the refractile druze was. And basically, you know it's going to eventually lead to atrophy. So when you see it, the important thing is to tell the patient the risk of what's going to happen. And certainly, we don't think any of our treatments would prevent it.
Right. And this is sort of what Bailey talked about earlier, the sealed RPE defect. Now you see the Miller cells kind of diving into that seal, unfortunately, and kind of blocking. Okay, we can argue about it, but I think it ended up in geographic atrophy, so we're the end stage is atrophy in that area, and near infrared helps you when you have something subfoveal, you're not sure, is it atrophy, is it not, and the autofluorescence can't exactly pinpoint it. The near infrared can be very helpful. And with that, I think I thank you all for your attention. I thank my panelists for an excellent discussion.